So many of you have likely written about community health workers. You will find us here in the United States working around community violence prevention in emergency department facilities. You may find us helping new immigrants and refugees navigate new health systems and eligibility programs. You may find us conducting home visits or working with families to ensure immunizations or oral health. You can always find us our state and local governments lifting up legislation and amplifying our roles. As the APHA has acknowledged CHWs as frontline public health workers, we have deep cultural origins that obviously extend as diverse as the United States is throughout the world, with deep sort of cultural experience, health beliefs, and religious practices around health, as well as shared experiences that are born and sort of tested here in the United States. Community health workers are those who have a calling for compassionate service. We accompany, we walk alongside, we partner with, and engender trust with our community members. We often live in the community, or we are peers with the same lived experience. We are HIV positive, we are living with chronic disease, we are cancer survivors, we are from the reentry community, we were once migrant health workers, etc. And to that end, we conduct a range of roles and skills and competencies that allow us to pursue improvement of whole health well-being. We are disproportionately female and females of color. We are often peers and survivors of many of the barriers to the social determinants of health or social drivers of well-being that many marginalized communities experience. Oftentimes, our funding reinforces this reality. CHWs often work in short-term grant or project-based funding. We are among the lowest paid out of all public health frontline workers. And often we are focused in programs and interventions that are reflective of and in fact are sort of impacted by the marginalization, the sort of siloed sectors that are persistent throughout the United States, and the historic sort of structural racism that has embedded itself throughout our systems and policies. We work in under-resourced communities often in a variety of different settings and across every sector. So you will find us as liaisons in education. You will find us working on the opioid epidemic. You will find us working upstream around housing and immigration, workforce development, as well as working in hospital systems and with primary care providers. We are bridge builders. We are navigators. We are health educators, but we are also community organizers and researchers and advocates. In the early months of the pandemic, many CHWs were actually being laid off or furloughed. Instead of public and private institutions and employers recognizing this critical frontline infrastructure workforce and the opportunity that it provided to engage deeply and authentically with community, a lot of our grant programs and our services were disrupted. And so NACHWA launched a national campaign to say that CHWs have a profound and urgent role to strengthen public health response during COVID-19. I hope that some of the tens of millions or even billions of dollars coming through the federal government will be invested in community health worker-centered and led organizations so that we can come through and out of this pandemic with enhanced capacity, not reduced capacity. There are ways in which we can ensure and advocate for increased and enhanced language access around testing and contact tracing and social care needs. The way in which the data that many CHWs collect needs to be disaggregated and analyzed so that we can dig deep into inequities in testing, inequities in contact tracing, and the ways in which CHWs can confront and dispel myths and racial discrimination that we're finding during this pandemic. Many community health representatives that are trying to address chronic disease, housing, immunization, or others go home to dwellings without running water or electricity. These are frontline public health workers who are attempting to respond to the pandemic while they themselves are yet under resourced. We do not have a vaccine now. And so we have time if public and private institutions will be authentic and will invest in real conversations and real community engagement to begin to not repair all of the trust, because I think that is a lengthy endeavor, but certainly to center trusted messengers and trusted organizations to begin to build bridges so that everyone who believes in the efficacy of the vaccine is available to have it if they need it. The vast majority of CHWs do not work out of health systems. The vast majority of them work through community-based organizations, and that puts them at greater risk because CBOs also often don't have the type of resource to get PPE, to get that sort of training, and to have sort of hazard pay and protections to allow CHWs to continue their on-the-ground work. There have been a number of different pieces of legislation that have been offered through the Senate and to a lesser degree through the House that include CHWs. But again, this is a sort of short-term funding around contact tracing and nothing sustainable. Context of the Navajo Nation, because if some of you were tracking the funding, you will know that up until June 2020, much of the funding that we saw across the country, the $1 billion here, the 2 billion, the 1.5, 500 million that was distributed through the states. If you went to the CDC website and looked at the tribal nations up until June, they had not received a penny. They had not received 1 penny to address the testing and contact tracing. Members of the Navajo Nation were asking people to send them masks so that they could do their frontline work of contact tracing and testing. So it's really a shame. And I hope, again, that more of these stories will be lifted up.
One of them would be farm workers. After all, you can't grow strawberries in your front yard. You actually have to go out. Usually, farm workers go out in packed buses. They work shoulder to shoulder in these large crews, these cuadrillas. They work in the packing houses. They work shoulder to shoulder. They are rarely offered health insurance. Latinos, even after Obamacare, are twice as likely not to have health insurance. And of course, as we get to places like farm workers, who are largely Latino, almost 100% immigrant, and probably 60 to 80% undocumented, depending upon the crop and the region, left out of the Affordable Care Act and other sorts of things. So when the pandemic finally broke loose, essential workers were protected. We thought everybody else could work from home. Farm workers still had to go out every single day. In fact, they were essential workers. They were given letters by the county saying, this person can travel because this person is an essential worker. And the state of California told the Spanish-speaking community early on, if you've got symptoms, if you have a fever, if you've got a scratchy throat, hable con su médico pronto. Well, here you have farm workers who don't have health insurance. So if I call a doctor, how am I going to pay for this? That's a lot of money. And secondly, by the way, we have this Latino physician shortage. I don't even know any doctor, much less one that speaks Spanish. I have low income. How am I going to pay it? And if you remember the first 2 months of the pandemic, you need to have a physician's recommendation to get the test. And there's, as you know, in healthcare, there's a whole jigsaw puzzle of who pays for what. If you were not covered, you could wind up paying anywhere from $100 to $2,000 for one test. Farm worker family of 6, 7 people, $100 each. That adds up pretty quickly. Then, of course, as a result of this, other essential workers, not only farm workers, but packing house workers, meat packers, truck drivers, gardeners, food industry workers, shelf stockers, grocery store checkout clerks. Imagine the grocery store checkout clerk will have about 300 people pass within an arm's length during a given shift. And for the first couple of months, they were not even offered personal protective equipment. So these folks that were working to make sure the rest of us could eat were far more exposed to coronavirus than those who were able to stay at home. Now, if you remember the first month or so of the shutdown when people were fighting in grocery stores over paper towels and toilet paper, well, if it weren't for these farm workers and truck drivers and packing house workers, etc., exposing themselves to coronavirus, we would have been fighting over the last sack of tomatoes in the store. That would have been some very serious fighting. So, moving forward now, because many populations of color tend to work in these occupations and industries that expose them far more to the coronavirus, with less access to care for testing, for treatment, for follow up, not surprisingly, Latinos have now one of the highest rates of exposure and of mortality in the state of California. So, finally, after being exposed, uh, a Latino, particularly a farm worker, comes into the ER with an advanced case. We had the case of the president of this country just a couple weeks ago suddenly show up, airlifted to an ER. That airlift, by the way, if you're paying out of pocket, was about $60,000. Got some extraordinary courses of treatment of things that just now, 2 weeks later, are being approved by FDA just to use. So he got access. It wasn't a clinical trial, because if it were a clinical trial, there's a 50% chance he didn't get remdesivir. Just looking at the cost of the course of treatment of the remdesivir, not the physician charge, not the hospital room charge, not the airlift charge, just that 6 course of treatment is $3,120. Now, as we look at your average farm worker from a study done by UC Davis, your average farm worker household income is 1,500. So that course of treatment that President Trump got at taxpayer expense would have been 2 months' salary for an average farm worker, because they usually don't have insurance because they're usually undocumented. Uh, so that farm worker's household, to pay for that, just that one item, would basically have to forego all food, all housing, all clothing, all transportation for 2 months. Well, if you go without food, your average person dies in about 40 days. That is what we have. As we look at Latino households, they tend to be lower income, but at about $5,441 average income nationally. Uh, Usually, they might have some access to health care. So for them, the remdesivir costs were only about 60% of their income. And of course, all non-Hispanic white households at $7,000, the remdesivir cost would be about 40% of your monthly income. Clearly, these treatments are very expensive, and with our patchwork of insurance, pricing, costing, and everything else, the ones who have done the most to keep this economy going, the farm workers who have kept us fed. Yes, we complain we don't have the same large variety we used to, but the shelves are not bare, are paying for this literally with their families' lives. Of what our president got for free, and you could add in the other $100,000 in hospital, physician, and air transport cost, simply is beyond the reach of your farm worker family that is feeding us every day. COVID is going to be with us for a while. We're going to have at least one more surge this winter, and if the Supreme Court, now that it now has its new member, takes this up, and if they decide to withdraw Obamacare, that's going to put us back to the days when we had over 55 million people without insurance. We got it down to about 20 million, but that's going to go back up to 50 million, possibly even more, right in the midst of a pandemic. It is a recipe for disaster.